I'm Dr. Paul Forfia. I'm the director of the Pulmonary Hypertension, Right Heart Failure, and Pulmonary Thromboendarterectomy program in the Temple Heart and Vascular Institute. Temple Heart and Vascular Institute is one of less than 5 programs in the United States that specialize in CTEPH. CTEPH stands for chronic thromboembolic pulmonary hypertension and results from an acute pulmonary embolism that does not resolve in the blood vessels of the lungs. About 5% of patients who have had an acute pulmonary embolism will not resolve their blood clots on standard blood thinners, will end up with a chronic scar-like clot in the blood vessel of the lung, which causes significant pulmonary hypertension and shortness of breath. So diagnosing CTEPH starts with just interviewing the patient, and then it goes on to looking at their heart on an echocardiogram, and then looking at their lungs on various forms of lung scanning. So the first thing that we're going to do is we're going to talk to the patient and try and figure out whether they've had a pulmonary embolism in their history or not. If they've had a pulmonary embolism, we want to know what the circumstances were surrounding that pulmonary embolism. And then of critical importance, is the patient still symptomatic weeks, months, or years after a pulmonary embolism? If they are, then the diagnosis of CTEPH has to go to the top of the list. The next thing we do is we examine the patient and we look for any signs of pulmonary hypertension on exam, including signs of right heart dysfunction. We use the echocardiogram to look for evidence of pulmonary hypertension, right heart enlargement, and also some special abnormalities on the Doppler exam that can signify blood clots in the lungs. And then lastly, if there's suspicion, then we go on to scan the lungs using 2 principal forms of lung scanning. The first is called a ventilation perfusion scan, and then the second is a contrast-enhanced CAT scan of the lungs. In both cases with lung scanning, we're looking for evidence of old blood clots in the lungs. If the patient has large blood clots that are located in the lungs relatively close to the heart, this is what we call proximal disease. In these patients, they typically are good surgical candidates, and the first line treatment for CTEPH is surgical. It's a surgery called a pulmonary thromboendarterectomy, and the initials we use for that long word is PTE. For patients who are not eligible for surgery, we do have medical management. There is one FDA-approved drug for the management of inoperable CTEPH. And then lastly, there's emerging evidence for the use of an angioplasty procedure for the treatment of patients who are thought to be inoperable but may be a good candidate for angioplasty. The pulmonary thromboendarterectomy, or PTE surgery, is a complex procedure. It does involve what's called a median sternotomy, which is an incision through the breastbone for full exposure of the heart. The sac around the heart is opened, and then an incision is made, a small incision is made in each pulmonary artery where the blood clots are, and the surgeon dissects down into the pulmonary artery, gets a hold of the blood clot, and gently pushes the blood clot and peels it off of the wall of the blood vessel. It's a very delicate operation. It can take time to do. Patients are on a heart-lung bypass machine, and during periods of time during the surgery, their body is cooled and the circulation is stopped in order to provide the surgeon with the best visualization to remove the blood clots. The patient is ultimately rewarmed, taken off of cardiopulmonary bypass, and then is brought back to the ICU for care in the ICU after the surgery. Within 6 to 8 weeks of the surgery, the majority of patients will experience a dramatic improvement in their shortness of breath. Many of them will be off of their medications to treat pulmonary hypertension. They'll be on a minimal dose of a diuretic, and many of them are off of oxygen. And for many of our patients, they've been on supplemental oxygen for years, and coming off of supplemental oxygen can be quite incredible for them. One of the most rewarding aspects of taking care of patients with CTEPH and either managing them with a PTE surgery or even medical management is that their quality of life can improve dramatically after surgery or after medical management.